Thank you very much, Karen. Thanks a lot. And I'm not, this is not a warning, but I'm telling you because other questions from neonatal sepsis and neonatal meningitis is coming to you and Dr. Sajjad because Dr. Polin and Dr. Haque is still sleeping. So he recorded that thing. So I have to ask, and of course, Karen did a lot of work in infectious disease. So I would like, Aiman, you can start with Dr. Sajjad and then
sure.
build up the discussion.
Yeah, thank you for both speakers. Excellent presentation. Assalamu alaikum, Dr. Sajjad.
Everybody.
My question about the screening protocol that you have for babies who are born to COVID positive mothers. In our protocol, we start the first screening for the baby at 24 hours, where you mentioned that in your protocol, you do it at delivery or after delivery directly. Do you know anything about like why this is variation? I mean, we were worried about like contamination, not really true, colonization of the babies. So can you comment on the timing of the first COVID test for babies who are born asymptomatic to a COVID positive mothers?
No, I don't think I mentioned that we should be doing a delivery. The protocol which I mentioned, it was saying either do one at 24 hours and second at 48 hours, or just do one between 24 and 48 hours. So I think probably it's the same as it's yours.
Yeah,
Karen, you have any suggestion about the timing of COVID test? Because we are doing at the time of birth.
In Boston, in Philadelphia, we have been starting at 24 hours and then repeating it 48 and 72 hours if the child remains in the hospital. Of the COVID positive infants that we've identified at Philadelphia Penn Associated Birth Hospitals, I think only one of them was positive at 24 hours. Most of the transmissions we've identified are horizontal after birth, and we identify them at the 48-hour screening.
Okay, so next, from the Dr. Polin lecture about the neonatal sepsis. Karen, he showed your publication also. So what is the latest you are doing? Because one question I received just now from the audience that if the baby is asymptomatic, but the CRP or procalcitonin high, what you will do? You will treat the baby, and I need your comment also, Sajjad and Aiman. So, Karen.
So we have moved in my centers to not using either the complete blood count, CRP, or procalcitonin as a screen at birth, either for term babies or for preterm babies, to make a decision about empiric antibiotics. In term babies, we do use the sepsis risk calculator models, and in preterm babies, we use the circumstances of preterm delivery. I'm not saying we never use a CRP or a CBC to make a decision. If we do that in hours or days after birth. We certainly do it when we're evaluating infants for later onset infection. But there are too many inputs around the time of birth that contribute to abnormal values in the inflammatory markers. Maternal inputs, technicalities of birth, just the natural rise and fall of those markers. And so we have really moved away from using them to make that decision at the time, near the time of birth.
Sure. Dr. Sajjad, what's your experience about that?
Yeah, I mean, we're not using the calculator. We're not yet there to understand and how to practice it. But at the same time, we're not using the CRP or procalcitonin at birth as well. We usually do it 12 hours or 24 hours after birth. But we have to start the antibiotics depends upon the clinical circumstances and the risk of sepsis in a baby.
I think, Dr. Junaid, the most important issue is that, first of all, when you have a diagnosis of chorioamnionitis, the gold standard for chorioamnionitis diagnosis is placental examination or culture. Now, in our setting, I don't know if you're Sajjad or Dr. Junaid, I know in the US, you send all placenta for pathology when you suspected chorioamnionitis. Now here, we don't have that luxury. So that's one. Second is that if you have a full-term baby who is asymptomatic and the mother have a suspected chorioamnionitis, we admit the babies to the NICU, which is not really what the protocol called for, because we want to assure the close monitoring of those babies. Those babies should be examined every 30 minutes for first 2 hours, and then 4 hours after that, every 4 hours for 24 hours, and after that it will be every 6 hours or more. But if you when we don't do any labs, because as Dr. Karen mentioned, if you have a CRP, there's a lot of things that can cause the CRP to go up, and then you're gonna get abnormal value, and people get nervous and they start antibiotics. So we don't start antibiotics, we don't do lab if the baby clinically well, full term we're talking about. If the baby is symptomatic, of course, you have to start treatment. If the baby is premature, we can use screening, and then depends on the baby's symptoms. If he's asymptomatic, you can wait. If he's symptomatic, you have to treat.
Karen, there's a question for you that, again, the practice is different in Middle East than in USA. So the use of or the treatment of CMV ganciclovir or ganciclovir for the 6 weeks or month, what is the benefit? Is this I mean only to protect the hearing, or there are much more to that? I mean, they just want you to elaborate a little bit more, because it's a long treatment, and many of the hospitals, they don't have even the ganciclovir, so they have to admit for 6 weeks ganciclovir.
Yeah, you'll notice that I didn't go over any literature around the medicine of ganciclovir, because there is none. Ganciclovir, valganciclovir, which is now orally available and actually very bioavailable, is not labeled for use in newborns for this indication, and there's no efficacy data. There's case reports that when infants have severe sepsis-like syndrome, people try it. And I did note the one study that looked at the reduction in viremia associated with starting it. It is a fairly, it has a lot of side effects. There's a lot of hematologic suppression that comes with it. And although there is an evidence base for hearing preservation in congenital CMV, there's really no organized evidence around whether it should be used in postnatal CMV. That's not to say it shouldn't be. It's just how to dose it, how long to give it, and what your endpoint is. So what people do is, if a child, develops what they think is an acute CMV pneumonitis, they administer it with the hope that it will be helpful. And theoretically, if it decreases the viral burden and viral replication, it should decrease the associated inflammatory response, which is primarily what's damaging the preterm infants. But it's an area that needs serious study. And there's a lot, at least in the United States. If you ask 10 infectious disease experts, you'll get 10 different opinions about how to use it in this setting.
Sure. Dr. Sajjad, there's a question about, you mentioned in your presentation about that one of the ways the baby can get COVID is the breast milk. So what is your practice that if the mother is positive and the baby is not positive, you don't allow the breastfeeding?
Breastfeeding is allowed. Even if the mother is positive, still the breastfeeding is allowed. And it has not been proven that the breast milk actually transmits the virus. But it has been proven that the breast milk actually transmits the antibodies, which are protective against COVID. So mother should breastfeed. If not directly, she can express the breast milk till she is negative and non-infective. Even during the active phase, she can have a face mask, and with all the precautions, she can and she should breastfeed.
There's one question about MISC in neonates, because I don't know if Aiman saw of any case, because we are designated non-COVID hospitals, so that's why we are not having those sick babies. So can you elaborate more? People want to know that you describe the signs and symptoms. So how early you can diagnose? Only on the basis of signs and symptoms, or is there any specific test of that particular syndrome?
Is it for me or for Aiman?
Yeah, for you.
Yeah, actually, Miss N is a clinical syndrome, but then we have to have some kind of biochemical markers. And there are a number which have been mentioned in the literature, but we have limitations to which we can do. For example, we cannot do the interleukins and many other things, but we can easily do the ferritin levels, LDH levels, CRP. So that's what we are doing. And the MOH criteria actually mentions some of these. What should be the level at the time of admission or in follow-up, and how rapidly these should be rising. And this is associated with the clinical condition of the baby, is in hypoxic respiratory failure, in high frequency oscillation and nitric oxide, and at the same time circulatory failure, leading a lot of inotropes. So of course he is very sick, and it looks like he has got this N. Then we also look at the multi-organ failure, how they are doing with respect to their kidney perfusion and urine output, what is the level of bone marrow reaction and platelet count and WC count, lymphocyte count, and all these things have to put together to say that whether the baby has Miss N or not. But these are new diseases, new syndrome, and that's why we want to share the experience. And I'm sure many people have much better experience than us, and we can learn from each other. And then probably the time is coming when the people will come with a consensus statements about what is the definition and how it should be treated. As I mentioned, HRCT is a very good tool to diagnose the pneumonia in patients with COVID-19. And there is a criteria for severity scoring in adults, a criteria with 40 and a criteria with 25 items. But in pediatrics and neonates, still we don't have the consensus criteria. Probably this needs to come in the coming days.
So there's another question about neonatal meningitis. So I will start with Karen. If you can answer, then I will, Aiman and Sajjad can also comment. About the lumbar puncture, you get a baby, you suspect infection, and then you suspect that it might be LP. So you did the LP, you have to repeat it if the LP become positive. Or what are the criteria to do the lumbar puncture in those babies? Karen, if you can comment on that.
No, the decision to LP in early onset infection is a hard one, because very often the infants that you are most concerned about are the most ill. And there's also controversy around the extremely low birth weight baby, especially if you're using IVH prevention protocol, where you're trying to keep the child midline and undisturbed. I think in general, the American Academy of Pediatrics guidance suggests that if you have a very high suspicion and you have enough clinical stability, you should do the LP prior to initiating antibiotics, so that you shouldn't delay the initiation to get the LP done. If you have done it and identified an organism, especially a high-risk organism such as Group B strep or E. coli, it is recommended that you do a repeat LP to ensure sterility and to ensure that the inflammatory response is declining. Both of those organisms can create complicated CNS infections, such as epidural abscess, for example, and GBS. These are not common, but the recommendation remains to demonstrate sterility of the CSF in the same sense that we do a repeat blood culture to demonstrate that you've cleared bacteremia.
Sorry. So in our units, what we do, as Dr. Karen mentioned, that we're really very careful about doing LP in the extremely low birth weight infants, especially babies like under 28 weeks, in the first 72 hours. So even if we're suspecting meningitis in the first 72 hours, we start meningitic coverage and then we defer the LP until 72 hours. And there's a study showed that there's increased risk of IVH grade 3 and 4 if you do the LP within 72 hours, if the extremely low birth weight infants. So we cover, we do wide spectrum coverage for meningitis if we have a high suspicion. And then we do the LP after the 72 hours. That's our practice. Now, to repeat or not to repeat, you know, if you have a full term and you have a GBS, then, you know, the recommendation is not, you know, if it's a normal course, you may consider to do LP, but you don't have to. But any other organisms, gram negatives or anything more than GBS, you need to prove sterility of CSF. Or if you have any complication, if you have a persistent fever or you're suspecting any brain abscess or ventriculitis, then you have to repeat therapy.
Okay. There's one interesting question by the audience. They mentioned about one publication from India, and they said in the cases of very serious sepsis, they do exchange transfusion, and it seemed to help according to this paper. I never heard of it, but they said, what is our panel's take on this and guidance? So if any one of you can comment on that.
I can't say I've ever done it. It is reported in older literature. It's going to be something that is probably only technically reasonable in a term infant. I don't think it's an established modality.
It's mentioned in some references that exchange transfusion can be treatment for severe sepsis, but then you have to worry about the risk of complication during the exchange transfusion. And if you have a good antibiotics available to you, then I don't think anybody, as Dr. Karen mentioned, have done exchange transfusion in severe sepsis. I know Dr. Sajjad.
Yeah, Dr. Sajjad.
So do you find it useful?
Yeah. What?
Yeah, you have found it useful because we have never done it for.
No, we have not. We've never done it. I mean, it's mentioned in the textbook that you can have exchange transfusion.
Yeah, we have never done it as well.
Yeah. I have a question, Dr. Karen, actually, about CMV, acquired CMV. If you have extremely low birth weight infant and you have a donor milk, the parents coming with a donor milk, what do you do with that milk before you give to extremely low birth weight infant? Do you test it? Do you do PCR or you test the mother? I don't know if it's a big issue in the US, but it's very common here in our area. And maybe Dr. Sajjad can comment on this also.
In the United States, we do have the advantage of pretty widely available donor milk from donor milk banks, and they do pasteurize the milk.
Yeah.
What you're talking about, we tend to refer to as informal milk exchange.
Correct. Yeah.
And it varies from center to center whether they test the milk or whether they ask the family if the donor is willing to have CMV testing. Interestingly, at Penn centers, we ask the family to sign an informed consent document that really lays out the risks of informal milk sharing, including the CMV issue. So it's a little bit difficult because families who want to do that generally feel very strongly about it, and we do not like to stop families from making decisions about their infants, but we do counsel them in a both direct way, and then we sort of legally document the risks that they're assuming with informal milk sharing.
When you freeze the milk, actually, you decrease the little bit of the CMV.
Yeah, you do. You decrease the CMV titer, and I think as Dr. Lanzieri's study showed, you can decrease the absolute incidence of identifying postnatally acquired CMV, especially if you're doing a surveillance study and you're really picking up all the asymptomatic cases. But for the sort of 500-gram, 23-week infant who's most vulnerable to getting symptomatic CMV, that degree of decreased infectivity doesn't seem to make that much difference because it's just an extremely vulnerable host.
What do you think, Dr. Sajjad? What's the practice in Saudi? I'm sure you have those.
We don't have the breast milk banks where we can get the milk from various sources, but we do have facility where individual mothers themselves, they bring their milk and we do store that and we do freeze that as well. And as long as the mother is healthy and has no clinical problems, we just feed that milk without any.
Do you get him to sign a consent when you have an informal milk sharing? That's with your parent. We do the consent exactly the same way that your parent mentioned.
We don't share much of the milk.
Okay.
So we don't.
But sometimes you get it like actually, you know, you don't ask, they don't tell you. But if you ask, they tell you.
Okay, so another question on my WhatsApp, that most of us, when we start antibiotic for 48 hours, the culture negative, we stop antibiotics. They are asking that, what about 36 hours to stop antibiotics? Karen, start and then
so
everybody.
My research group has really done a lot of work on this recently, looking at time to positivity of blood culture. And what we say to folks is that if you do have good local data and you understand the time to positivity results from your laboratory, it's not unreasonable to use more of a 36-hour cutoff. We did a big study with the Kaiser Permanente group in California that I collaborate with, purposely to take different centers with different policies and different blood culture machines to try to look at whether a time to positivity based process would be reasonable. And 36 hours really identifies the vast majority of early onset pathogens. We're preparing a manuscript now around late onset sepsis, and it does get more complicated. The pathogens are different, and there's a lot more pre-treatment going on in that setting, and so it's less clear. It's certainly true that if you work at a center where you get a blood culture and you send it right, usually downstairs to your lab in the basement, that is different than if you're a center that sends blood cultures to an off-site facility, because that, what we call pre-analytic time, can impact the time to positivity as well. I think also there's increasing data around how long some of these antibiotics endure in our tiny babies. And we probably underestimate just how long a 1,000-gram baby has an effective antibiotic in their bloodstream. I'm hoping that over time we'll have better pharmacokinetic data that will also inform that decision.
Sure. We look at our local data actually in our hospital, and we publish this in the for the time for positivity for early onset sepsis. We found that vast majority of the cultures grown within 24 hours, with one exception, which is staph epi. So if you don't have a high, strong, suspicion of staph epi, or early onset sepsis is not going to be on the top of your list, it's reasonable. I think the most important thing here is the volume of blood that you send to the lab. If you have a standardized, guidelines for doing at least 1 ml of blood, don't do like a few drops of blood, then time positivity will become very important. And I think within 24 hours, the vast majority will be positive. It's going to be positive.
Yeah, we actually do the same, particularly in early onset sepsis. We tend to stop the antibiotics between 36 and 48 hours, particularly if the baby is clinically well and all other parameters like blood counts and CRPs and everything is normal. So we tend to stop it as quickly as we can, usually between 36 and 48 hours.
Thanks a lot. Because of the timing, Dr. Joseph who is already logged in, and my friend Dr. Sridhar. So we have to start another session because Karen, Dr. Sajjad, I have few more questions. I will email to you definitely. And at your free time, please answer that. There are a lot of, because you are covering neonatal sepsis, neonatal meningitis, and CMV and COVID.